Hi, Lauren.
Hi, Lauren.
Morning, how are you?
Very welcome.
Good.
We've just met.
But that, I think, is the nice thing of organizing a webinar, meeting new people.
Yeah.
Oh, absolutely. Yeah, it's opened up so many more networks and avenues for communication, hasn't it?
Exactly, yes. So also still working from home, I see.
Yes.
Yeah.
Yeah. Sorry about the messy background.
Oh, no, it looks good.
Far too many books in this house. Yeah.
Yeah. It always gives a good impression, lots of books.
I guess so.
See, I quite like my background, but I was just doing a research interview just now, and my dog chose partway through the interview to start crying because he wasn't centre of attention. So I don't have a problem with the background in terms of what it looks like, but just sometimes we get some animations from the dog as well.
Yeah. Hello, Peter. Good morning.
Morning.
Hi. So it is 12 o'clock.
Yeah, it's 12 o'clock. We are not yet with the full group, but I assume a lot of people will join us in a few minutes. So they will appear and make sure that they will have their contributions as well. Short introduction. First, myself, I'm Diederik Arendonk, coordinator of the European Forum for Primary Care, host of this webinar and host also of the working group on prison health and primary care. But the real host and your coordinator is Anke van Dam. She will do a first presentation, an introduction, and then following other experts in prison health and primary care. What I would like to stress is that you keep your microphones shut, that there is no interference of sound. If you want to say something in the discussion, I can provide you the floor, but indicate this with your contribution in the chat box. If you have questions, and I recommend you to start posing your questions already from the start of the webinar. If you have a question, put it in the chat box and I will collect them and make sure that the presenters will be confronted with these questions or remarks or whatever. Having said that, I think that's it from my side. I will close my camera. I will start up the presentation of Anke, and I will. I wish you all joy with the webinar and the presentations. Anke, the floor is yours after I have started the presentation.
Okay, thanks so much, Diederik. A warm welcome to the webinar on cases of primary care in closed settings and prisons. My name is Anke van Dam, and I will be your facilitator for this webinar. I'm a member of the advisory board of the European Forum for Primary Care. And for those who don't know the European Forum for Primary Care, the aim of the forum is to improve the health of the population by promoting strong primary care. And this is done by advocating for primary care, by generating data and evidence on primary care, and by exchanging information between its members. I'm also chair of the working group on prison health, which is the organizer of this webinar. And I'm very pleased to see the interest to this webinar from people from all over the world. We have people from Australia, Indonesia, Belarus, and other European countries. And once again, thanks much for your registration. I'm happy to see that many people care about the health of detainees. I have myself a specific interest in prison health. I've implemented activities in prisons in my work at AVU International. And my work was related to prevention, treatment and care of HIV, tuberculosis and viral hepatitis in prisons. And prisoners are a group that is often denied healthcare, and prisoners actually should have the same care as is given outside of the prison. So can I have the next slide, Diederik? So this is the overview of the topics that we will discuss during this 1 hour. And we have a very interesting lineup of speakers. We have cases from the UK, no, from England, sorry, and Wales. And we have a case from Kyrgyzstan. And then also we will introduce you into the research that we are doing to develop a position paper for the European Forum. And hopefully we have enough time for further discussion because we are very interested in hearing your experiences and your experiences also with hurdles and obstacles in prison health. Can I have the next slide? And I think a lot already is done with regards to prison health. And I also put a quote from Dr. Kluge, who is now the director of WHO Europe. And just actually to demonstrate you again that there is the right to health. It's a human right which everyone is entitled, and that is the right to health care. And like I said, a lot of things have happened already with regards to prison health. UNODC developed the standard minimum rules for the treatment of prisoners, the so-called Nelson Mandela rules. There's also a very detailed document on good governance for prison health in the 21st century, also developed by the UNODC. And also the Council of Europe developed European prison rules. And there's a lot of information, and I would say on paper, a lot of guidelines how to organize prison health all over the world. But in practice, things can be really different. Next slide. And we are looking into these practices in the working group on prison health, the working group of the European Forum. We were established at the beginning of 2020 and 2019, beginning of 2020. And the goal of our working group is to increase awareness among primary care practitioners and policymakers to improve care for prisoners or ex-prisoners, and to come up with a position paper, to come up with recommendations to improve the care for prisoners, and also specifically to improve the care, the continuum of care, once prisoners are released. And these are the questions that will be addressed in our working group, and Peter also will come back to that in his presentation. We have planned some activities in our working group, and the first activity was a survey to get a better idea how prison health is organized in the different countries. We have received now 4 cases. So I will come back to that later, but of course we'd like to collect more information and more cases from other countries. So if you are interested to fill in the survey, please let us know. And we will also make sure that the survey can be accessed on the website. I'm now coming up with that idea, Diederik, but maybe that is a good idea. We have now 4 cases collected, and that was also reason for us to organize this webinar and to share with those who are interested how the situation is organized in the different countries, and already come up with some challenges that we face in performing good prison health care. So Peter and his colleague Anja, they are doing some research, and like I said, Peter will come back to that, and all that will be the input for a workshop that we are going to organize during the European Forum for Primary Care conference in Bergen in September this year. And then hopefully we can finalize the position paper and take it from there, because the ultimate goal is to advocate for a better primary care in prisons and a better continuum of care. And I think this was my last slide. So let's move on to the program and to the first two speakers, which is the case from England and Wales. And some of the cases will be presented by Dr. Lauren Smith. And Lauren joined the University of Lincoln in April 2020, having spent over 10 years working as a practitioner within the criminal justice system. In her previous employment, she supported people at various stages within the criminal justice system, including courts, prison, and probation. She supports men to prepare for release from prison through providing advice and guidance in relation to accommodation, employment and training, and finances. And she also conducts qualitative and quantitative research, which focuses on the resettlement and reintegration of people with convictions. And she will be accompanied in her presentation by Dr. Coral Söderfeld, who is a research fellow in the Community and Health Research Unit at the University of Lincoln. And she's also part of a group of colleagues that have an interest in conducting research in the criminal justice system. Her main area of research interest is understanding and addressing the health needs of people in the criminal justice system, and she's currently leading a study on the impact of COVID-19 on probation's health-related role, and is about to start leading another study about mapping the health needs of people under probation supervision and developing indicators for the quality of care that they receive. Lauren and Coral, Lauren, you will start, right?
No, me to start.
Oh, Coral, you start. Sorry, please.
That's all right, no problem. Thank you. So I'm Coral and I'm joined by my colleague Lauren, and we thought we'd divide the presentation between us. So I'll start off by just providing a broad overview of how healthcare is provided in prisons across England and Wales, and some of the challenges that we face in terms of continuity of care. And then Lauren is going to talk through some case studies from her practice experience. So the way that primary care is provided in prisons in England and Wales is a little bit complicated, simply because there are quite a few different organisations involved. So since 2018, we've had a partnership agreement in place for English prisons between NHS England, Public Health England, Her Majesty's Prison and Probation Service, the Ministry of Justice, and the Department of Health and Social Care. One of the objectives of this partnership is to support access to and continuity of care through the prison estate, including into the community. So healthcare in prisons is commissioned by NHS England, who are responsible for the commissioning of healthcare in all secure environments. And they have a health and justice team. Whereas healthcare in the community is largely commissioned by small groups of GP practices, which we call clinical commissioning groups, or CCGs. And these small groups are responsible for kind of small regions of the country, and they commission the healthcare for those particular regions based on population need. And alongside that, other services like drug and alcohol services are commissioned through public health departments. So if we think about the types of primary care service that you might expect to find within a prison, I've heard that referred to as being like primary care plus. And that's because you would find a whole variety of different professional roles. So you'd expect to see GPs, you'd also expect to see nurses, and that can be different types of nurse, from general nurses to mental health nurses. But you would also find a whole range of other healthcare professionals working within prisons. And that can include things like dentists, opticians, and occupational therapists as well. And the providers are meant to ensure that people in prison receive the same standard of healthcare as people living in the community. But exactly which organisation provides the healthcare within a prison and exactly which types of services are provided will vary from prison to prison. And that's to be expected because different prisons will have different types of population with different types of health need. And the idea is that the service provision should be tailored to those particular health needs within that particular establishment. So I think that often the standard of healthcare within prisons is actually quite good, and prison can provide a place in which people with often quite complex range of health needs are able to start to access the care that they need. And if anything, I would say the challenge can be just the length of time that people are within the prison environment for, and the fact that you know, sometimes teams have very little time in which to try and make a difference to somebody's health. Because continuity of care as people move into and out of prison can be quite variable, and I think has been recognised as an area that needs improvement. It was something that was highlighted in the NHS 5-year forward view recently as an area needing improvement. So there are a number of different things that make continuity of care difficult. So sometimes people can be released from prison at short notice. Sometimes they can be released without accommodation, so they're homeless. Sometimes they are released without being registered with a GP in the community. And there are particular challenges for women as well, because the female prison estate is much smaller than the male prison estate. So often women are imprisoned a long way from home. And because the services in the community are commissioned on a kind of small region basis, that can create difficulties in terms of prison healthcare providers being able to communicate with an unknown provider a long way away, essentially. There can also be issues around people that are receiving medication within prison being able to continue to receive that on release. And that's something that often shows up in probation research, particularly when you talk to people that work within probation approved premises, which are kind of secure environments that certain people convicted of maybe more serious offences are held in for short periods of time. Often you'll hear the staff working in those environments talking about the challenges that they face in terms of making sure that people are able to get access to the medication that they need. And there can also be problems with information sharing between different providers. And these problems are serious because they can result in really negative consequences. You know, we know that, for instance, rates of death on release from prison are much higher than those found in the general population. But it's not all bad. In some cases, probation are able to do through the gate work. So they are able to work with an individual to understand their health needs before release and to help them to register with a GP in some cases. And we also now have a new pilot project based with NHS England, which is called the Care After Custody Reconnect service. And that's aiming to address issues around continuity of care. So that service is aiming to work with people before they're released and to address some of the issues that we currently have around transferring patient records between organisations. So the idea being that a GP based within a prison would be able to directly transfer records to a GP based within the community. So that is a very brief overview. And I'll hand over to Lauren now so that she can provide some examples of that from practice.
Thanks, Coral. I think that sets the context really well in terms of healthcare across England and Wales. And just to reflect on a couple of things that Coral talked about. So the case studies that I'm going to go through are case studies from practice. So it's important to keep that in mind as I'm talking about them. They haven't come from academic research. As Angus said at the start, I've only recently moved over from being a practitioner into academia. So these case studies studies are case studies from mine and colleagues' practice that have been shared with permission, just to illustrate some of the difficulties. I think there is a scarcity of research, particularly in this area, around that transition from secure settings into the community. So I think case studies such as this, even though they are perhaps somewhat anecdotal, do serve to illustrate some of the challenges that Coral talked about. So that's what I'm just going to briefly go through. And as well, just something else that Coral picked up is that actually generally in prisons, healthcare is good. So having worked with people on their transitions from the community into prison, as well as their transitions from the community out of prison, it's actually, I would say on the whole, it's much smoother when somebody is going into prison to get that access to health services. People generally can be seen very quickly on the same day, and will have access to medications and any substance use scripts that they need. They'll have access to those much quicker than what they would have in the community. But these case studies that I'm going to talk about, so I've got 3 where there have been particular challenges, and 1 that is a little bit more positive just to end on, and then just a brief slide just to pull together some of the themes that I think come out of it. But there will be other themes that people pick up on as I'm talking as well. So the first case study is a gentleman who had spent 17 months in prison and had a diagnosis of schizoaffective disorder. And in many prisons in England, each prison has their own process, but in this particular prison that he was in, he was required to collect his medication from what we call a medication hatch, so to go and see a nurse on the wing and pick up his medication before he was released from prison. That was a slight change to his routine because people are unlocked for release from prison very early in the morning on the whole, and normally he wouldn't go and access his medication until much later in the day. So through miscommunication, lack of communication, he didn't know that he needed to go to his medication hatch to go and get that medication before he went to the prison's reception to get ready for release. So as a result of that, and no checks were done during the release process, so as he journeyed through reception, which is where people are released from, he ended up walking out of those prison gates without his medication that he required on a daily basis. He did have a mentor who was supporting him on release to attend appointments. She wasn't just working with him on the day of release, she was there sort of for a few weeks post-release. But she was attending the appointments with him on his release day. He had a number of different appointments to attend. And he was partway through an appointment with a housing provider when he suddenly had this moment of thinking, I haven't got my medication and I really need my medication. So he hadn't taken it that day and he had nothing for the foreseeable either. So the mentor helped him or contacted the prison herself to explain what had happened. And the prison said that because he had already been discharged, he wasn't within their remit anymore and therefore they couldn't help. So even if they went back to the prison to collect the medication, they couldn't provide it to him because he'd already been discharged. So he contacted his GP and explained the situation again, and was told that there were no appointments available for 1 week post-release. So that would have meant him going without his medication for a full week. Alongside this, he had previously expressed thoughts of suicidal ideation, and whenever there were particular challenges in his life, they could be a trigger for that. And he had been alcohol dependent as well. So, it, really complex situation. Fortunately, his mentor stayed with him throughout that day and throughout this experience that he had. And she actually phoned the GP and advocated on his behalf, reiterated the situation again, and quite assertively had to say to the GP surgery, he needs this medication. He cannot go without this medication for a week. Unfortunately, the situation was resolved. So they were able to go and collect that medication the same day. Had she not have been there to support that situation, we're not sure what the outcome would have been. Obviously, she was able to get him to the GP to collect it and that sort of thing as well. So that's the first case study. If we could move on to the second one, please. Thank you. So this is just a very brief one, just to illustrate some of the logistical issues that sometimes people have on release from prison. So this particular person was released to the county of Lincolnshire, which if anybody has visited Lincolnshire, you will know that it's a very rural county in England, and most towns are about an hour away from each other. So this person had appointments in 3 different towns across Lincolnshire. So just released from prison, quite disorientated, had got the train back to Lincoln city centre, but then had these 3 appointments to deal with. So he needed to be in Lincoln to access a night shelter, to access accommodation. He needed to be in Grantham, a further hour away, to go to his probation appointment so that he didn't get recalled to prison. And he needed to be in Boston, another hour away, so it's sort of a triangle of towns, to access the substance use service, to have his appointment there. He didn't have access to transport, so would have been reliant on public transport, and had limited funds through a £46 discharge grant, so not a lot of money to be able to pay for that transport. And it just, in terms of the public transport in Lincolnshire, it's not great either. And so physically being able to get from Lincoln to those other 2 places on the top of the train journey he'd already done from the prison, it just wasn't practical. It just wasn't going to happen within that day of release. So had he have not again contacted a mentor to help him to resolve that situation and get things moved around, he would have been left making the decision of, well, which do I access? I need to go to probation, else I'm going to get recalled to prison anyway, but I also need a roof over my head tonight. But actually, I really need to go to my substance misuse appointment so that I can continue my script. So would have had a really difficult choice to make had somebody have not been able to intervene in that situation. So again, a really challenging situation for that person. If we can just move to case study 3.
Lauren, sorry to disturb you. So we are a little bit short of time. Can you maybe...
I'll run through this one, yeah. No worries. So this is, there's quite a lot of information on this slide, but this is a very brief one. So essentially this person was released from prison and went to his GP surgery to find that he was no longer registered, but they couldn't tell him why. He then went to another surgery and was told that he could not register, and again wouldn't tell him why. He was working with a professional who eventually, after some degree of time, managed to ascertain that he was on something called the Special Allocation Scheme. So he'd been barred from several surgeries because of previous verbal aggression, but nobody was able to tell him that until she found out that information. So he then was required to register with a surgery out of town, and was very much limited in terms of the times and dates of the appointments that he could access. And then there's just one final case study, if we can just move along to that one. So this is a slightly more positive one. It doesn't start out great, but he was released from prison and went straight to hospital. Once he left hospital, he'd had some time in hospital to reflect and think, actually, now's the time to start making some changes. I need to get my health back on track. I need to get my life in order. And he attended his GP, who had known him for a number of years and was very experienced in supporting people with complex needs, and knew him and his family well. And when he communicated the fact that he wanted to change, his request was met with empathy and understanding. And as a result of that, the GP was able to build a really positive relationship with this person, and to be able to offer holistic support. So not just the support that he'd gone to on that particular day, but it moved into things like wellbeing support around dietary advice and smoking cessation. So a whole package of support was put in place that really hinged on this positive relationship that the GP had with that person and their response to his request on release from prison. So I've just got one final slide, just to pull together some of the themes very quickly. If we could move on to that. So I think through those case studies, the importance of clear communication and checks prior to prison release are really important, and that understanding of the bigger picture and how different services can link together. So in some of those case studies, the services had done everything that they were expected to do, but they'd done it in isolation rather than a coordinated approach. And I think it also illustrates the importance of having people available on release to support people to solve problems should they arise, and the importance of relationship building and an empathetic understanding when somebody approaches them. So that's it. Thank you.
Thank you very, very much, Lauren and Coral, for this introduction into prison health organization in England and Wales. And it's always nice to hear cases, because that makes the discussion lively. Then you get a better picture indeed what kind of problems prisoners and ex-prisoners face. We move on to another part of the world, and that is Kyrgyzstan. And the next speaker will be presenting, that is Dina Masalimova, my dear colleague. She's project manager at AFU Kyrgyzstan, but she's also representing AFU Partnership at the steering committee of the Health in Prison project of WHO Europe. And Dina has an extensive experience in working in prisons. And recently, she implemented a project to increase the HIV testing uptake in prisons and to ensure the start of and adherence to HIV treatment. Dina, the floor is yours. And please try to speak in the time.
I will, Anke. Thanks for this introduction, and thanks for inviting me to present at this very important webinar on healthcare in the detention today. So in this presentation, I would like to give you some information about how continuum of care and support is organized within the penitentiary system of the Kyrgyz Republic. Please, first slide. So for those of you, for those of you who have not been to Kyrgyzstan, I'd start with some quick facts about the country. It's a small country located in Central Asia, and it's a former Soviet Union country. The population of the country is 6 million people, but due to the fact that it's a lower middle income country, almost 1 million of its citizens had to go abroad in order to find a job. So out of the remaining in the country 5 million people, almost 7,000 are currently incarcerated. Next slide, please. So here you can see how the penal system in the country is organized and what ministries are involved in providing custody and health care in it. Upon arrest, the suspect goes to the police detention facility. There are 43 police detention facilities in the country, and they report to the Ministry of Internal Affairs. There are no medical departments within the detention facilities. If needed, healthcare specialists from the nearby public medical facilities are invited. Next, if the suspect goes under trial, he or she is transferred to the pretrial detention center. No, please go back to the previous slide. Oh, yes, thank you. There are 9 pretrial detention centers in the country. They all report to the State Penal Service. So the full name of the service is actually the State Service for Penalty Execution, but I know that it sounds bad in English, so I will not use this formal name for this presentation. The status of the service is equivalent to a ministry. It reports directly to the government. And next, those who get convicted are transferred to prison facilities. There are 11 prison facilities in the country. All of them have, and pretrial detention centers have their own medical departments. These medical departments report to the State Penal Service and work completely independent from the Ministry of Health. And lastly, there are 10 open-type settlement facilities under the State Penal Service. And the settlement facilities have no medical departments. Prisoners are supposed to get health care from the public healthcare facilities. Therefore, as you can see, there are 3 ministries and agencies involved in provision of health care and custody to people who are detained and to people who are imprisoned. And the smooth work of these agencies require a lot of coordination efforts. Unfortunately, not always these coordination efforts are in place. Several years ago, the Prime Minister of the country visited one of the prison facilities, and he made an order that the prison healthcare system should be transferred and become part of the public healthcare system. However, neither the Penal Service nor the Ministry of Health demonstrated willingness to do it quickly. The Penal Service claimed that it could negatively affect custodial and security issues, while the Ministry of Health understood that it would be an additional burden to them and would probably come with very limited additional resources in order to improve healthcare in prisons. So now let me give you a little bit more information about each type of facility. Now, next slide, please. So the temporary police detention centers, as I have mentioned earlier, have no healthcare departments. People are often detained on the streets, and they, of course, do not have proper supplies of medications needed to treat their chronic diseases, including HIV. And in order to get access to such medications, they need to inform a police officer that they have some chronic illness, and this police officer will then contact a public healthcare facility or allow him to deliver the necessary medications from home. Unfortunately, when it comes to diseases which might cause additional stigma and discrimination, like for example HIV or drug use disorders, prisoners or the detainees are often not willing to share this information with a police officer, because it might lead to worse outcomes for them in some cases. But if a detainee requires medical support, this support will be requested from an external medical specialist. Unfortunately, this requires a lot of paperwork to be done, so it's not what happens very often, let's say. Next slide, please. So if the person is convicted, he or she goes to a pretrial detention center. Both pretrial detention center and prison are part of the state penal system, and they have their own medical departments. People who work there are employed by and they report to the penal authorities directly. So below you can see some problems and difficulties related to this situation. First is the dual loyalty conflict. It may be defined as a clinical role conflict between professional duties to a patient and obligations to the prison administration. For example, in some cases, prison administration may pressure healthcare professionals not to provide evidence-based treatment available to the community for financial reasons or for security reasons. It's also very important to mention that in post-Soviet Union area, prisoners are not very much encouraged to cooperate or interact with the prison administration very often. And when prison healthcare doctors are part of the prison administration, they face additional barriers related to building trust relationships with their patients. It's also important, same as mentioned by the previous speakers, that data on health history and records might be available much later after the person is admitted to a prison facility, and in this case, treatment might be delayed. Another difficulty related to the prison healthcare system working separately from the public healthcare system is that it is not controlled by the health authorities, and people who work within the prison healthcare do not have access to postgraduate education, which means that newest clinical protocols might come with some delay. But there is also a positive side in it. It is that prison medical staff is eligible to earn this military ranks within the military rank structure. So it means that they get better salary and that they can retire much earlier than in the community. And it makes this work a little bit more attractive to the professionals. But in general, there was an assessment held by ICRC a few years ago, and the finding was that prison healthcare is worse than that available in the community. As mentioned earlier, many prison medical facilities lack qualified doctors with higher education. Unfortunately, some of them, even big ones with more than 1,000 prisoners, only have nurses or felchers. In some facilities, qualified doctors can be contracted from public healthcare facilities. They work part-time, but they are not eligible for this military rank promotions and benefits, and this actually means that this is not very attractive to them. There are also two prison healthcare hospitals in the country. One is for TB patients and one is for the general prison population. However, transfer to these hospitals may also be a problem, especially for those prisoners who belong to the lowest strata of the prison population. As you might have heard, in post-Soviet countries, the prisoners are divided into several stratas, and the lowest of them, prison outcasts, are something like the untouchables. And even if they want to get transported to a prison hospital, unfortunately, they cannot be in the same vehicle as other prisoners. And this means that they face even more barriers with accessing healthcare within prisons. Also, if the prison medical system, can you please go back to the previous slide? I'm sorry, I'm being slow. So, as prison system has its own healthcare unit and it doesn't report to the Ministry of Health, its funding also comes from the budget of the penal authorities. Unfortunately, in our country, the penal authorities are allocated only 30% of the budget that they request from the government. And healthcare is not their priority. It means that actually these hospitals have very poor conditions. There are not enough medications and equipment. And there is also lack of cooperation between the public, civil and penal healthcare authorities. Last year, in the end of the last year, actually an order was signed in order to increase this cooperation, and I hope this happens in 2021 and it will result in better health outcomes for prisoners. So on this slide, you can see the findings of the 2019 medical screening, which was performed by the Penal Medical Services. And it shows the percentage of prisoners in each prison facility and in each pretrial detention facility in the country who have some illnesses. So you can see that 30 to 75% of prisoners have some illnesses. And on the next slide, you can see the prevalence of this of the illnesses within the penal healthcare service. So the most widespread disorders are digestive system disorders and urinary tract disorders. As you can see, mental health and substance abuse disorders account only for 4% of the disorders registered during this medical screening. And when we were discussing this with Anke, we thought that it might be because the assessment team didn't have enough attention or probably enough qualification in order to properly diagnose the mental and substance abuse disorders. Because in fact, according to one of the recent IBBS surveys in prisons, almost 40% of prisoners have hepatitis C, are estimated to have viral hepatitis C, which might indicate that at least 40% of them have some drug use experience and it went undiagnosed for some reasons. Next slide, please. So it's also important to mention that our prison system is very much open to cooperating with the non-governmental sector. In particular, our organization, AFIA Kyrgyzstan, has been a long-standing partner for the penal system. We have worked together for more than 15 years and implemented a number of projects, mostly in the sphere of HIV prevention and treatment. And on this slide, you can see some of our main achievements made within one of these projects, which was an HIV REACT project, which lasted for 5 years. So we worked together on several levels, and on the technical support levels, we helped the penal system to determine gaps in prison regulatory framework related to HIV, and we helped them to draft several instructions, including the instruction on implementing the harm reduction programs and HIV and STI prevention programs. We also tried to build the capacity of medical and non-medical prison officers, and we reached over 800 officers in 5 years of the project implementation. But what's even more important, prison authorities allowed our peer-to-peer consultants to come to the prison facilities and provide support services for people living with HIV. And due to this support services, you can see that the percentage of prisoners on antiretroviral treatment increased from 82% to 94%, and the percentage of those who have their viral load suppressed increased almost 3 times, from 26% to 75% in the pilot prison facilities.
Tina, may I ask you to wrap up?
Okay. So the next slide, I'll try to go quick. It's the one of the last slides. The open type settlement facilities is the last stage of a prison sentence for many prisoners, and it has no medical departments. Prisoners are supposed to reintegrate into society, go out of this open type settlement facility, and use public health care services. But unfortunately, many prisoners do not have any ID documents, which are required to get registered with the medical facilities, and they cannot access public health care. Also, stigma and discrimination towards former prisoners, including self-stigma, is a very significant barrier. And in addition, some prisoners are simply not allowed out of the open type settlement facilities due to violations of the internal rules that they have made before. And in this case, they have to inform the head of the prison facilities that they need to go to the AIDS center, for example. And of course, in many cases, they are reluctant to do so. So next slide, please. The transitional period before and after release is actually mostly managed by NGOs. There are no pre-release programs for prisoners run by the government. Such important services as temporary housing, social support, community reintegration is dealt with by NGOs, but currently there are no projects available in the country which would target former prisoners, and that would be large scale enough to reach a lot of prisoners. So that's basically it.
Thank you so much, Tina, and sorry to hurry you up with the presentation, but it was very interesting. It's always good also to hear the examples of countries so, well, actually quite different from the European context. Then we move on to the next presentation, and that is from Peter Groenewegen. And Peter is a senior researcher and former director of NIVEL, the Netherlands Institute for Health Services Research, and he's also a retired part-time professor at Utrecht University. He was co-founder and former member of the executive board of the European Forum for Primary Care. Peter is a sociologist by training, and his main research interests include organization of primary care, international comparative studies, health policy, and healthcare organizations. And he will guide us through the work that we are doing for the position paper. And he's doing the research together with Anja Dirkswager, who is a senior researcher. He's also a senior researcher, but at the Netherlands Institute for the Study of Crime and Law Enforcement. Say it again? Okay, I think someone unmuted. Peter, please.
Yeah, thank you very much. Diederik, you have put on the final slide, and I promise to be very quick, but not that quick. Okay, no, stop. One further. No, go to, yes, no, one further, yes. Because I think we could concentrate for time's reason on a very few important things. You can all read what's on the slides, but I think one of the issues is that a lot of people who are imprisoned at one point in time cycle in and out of prison, and so that emphasizes the importance of a link between the prison health situation and the community health situation. And if you look at the background, socio-demographic background of people in prison, you can predict that there will be serious consequences for their health and care needs. Diederik, can you go to the next one? Is Diederik still there? Yes, great. We're for a position paper that we're making for the Forum for Primary Care with the working group. Anja and I are looking at what's known about prison health and
Ha
prison
yok be, unuttu onu.
primary care.
Zaten
So-
sen olduğunu hiç söylemedik bu arada, değil mi? Hiç söylemedik. Biliyormuş gibi.
Sorry, can someone unmute the microphone? Can we all
No, there is
Bence söyle. Ben olsam söylerdim.
unmute.
Ama benim söylemem benim için daha kötü. Çünkü ben
Ipar, can you mute your microphone?
hayır anladım. İrem sandığımdan daha zekiydim. Direkt anlar.
I have
Didrik,
no
can you
clue
mute
who
her?
it is. So I'm trying to solve it from a, but
Ya şöyle diyeceksin. Bendim o kişi. şöyle oldu.
İlk o kişi söyledi ama ondan bir önceki kaynak söyledi. Ben de oradayım.
Bu kaynak sen oluyor.
yeah, here it is. Sorry, I close it.
Şöyle. Sen sonuçta
Yeah, go ahead,
Well-
Peter.
Yeah, it's great. Even during this COVID period, you need sometimes just to chat to people. So it was nice to hear a voice. But, no, as I said, Anja and I are working on on parts of the position paper, and particularly looking at the literature about prison health, and in particular prison health care and the role of primary care. And very quickly, there are there's really a high burden of both physical and mental health problems, substance abuse problems in the prisoner population, with high risk groups, women, very young people, and very old people. There's an aging population in prisons, and there is a high mortality, especially shortly after release from prison, sometimes due to an overdose of drugs or other or suicide. So there is a need for early contact with primary care, and that's something that we should learn. It's also something that came up in in what Coral told us, and the cases that Lauren presented. Very good illustrations of this need of very quick contact with the healthcare system. Diederik, the next one, please. Well, the conclusion of the previous slide is that prisoners have complex health needs, and that these health needs are often amenable to good quality primary care, both during their prison time and afterwards. But there's not much in the literature about this. Much of the literature is about the either separate interventions, such as mental health interventions, and whether they're effective in the prison situation, or they are about the governance of prison care, but not so much about the quality of care within prisons and the what I call key generic characteristics of care: person-centeredness, quality, comprehensiveness, accessibility, continuity, and coordination, and of course how this can be organized. So we didn't find much literature in this area. Diederik, next one, please. If you look at the role of primary care, I haven't found any literature on the role of primary care during the prison time. The focus is on primary care after release, and there's some research about that, and mainly Australian research, but it is informative about the role of primary care after people have been released, and it emphasizes the importance of quick contact with primary care to help people navigate the healthcare system. What I want to do now is to go to this final slide that I have, which are elements for discussion, and that could be part of a position paper, so that we can have some discussion in the final 8 minutes of this webinar. First of all, I think it's important that prison healthcare is part of public health and primary care, And maybe I could add that it should be linked to social care as well. If you look at the cases that were presented with the importance of accommodation and transport and things like that. Primary care practitioners such as GPs meet ex-prisoners in their practice and should be aware of that. Depending on how many prisoners there are in a country, at least a couple of them are part of the primary care population at any point in time. The third important issue, which was illustrated by Dina, is that the equivalence principle, the care in prisons should be equivalent to care outside, and in many countries that will not be the case. Good prison care is an opportunity to address poor health and to reduce health inequalities. And that's not only the prison care, but it also involves the coordination and continuity with care outside the prison. There should be connections between and integration of care in prisons and the community. There's a need for some kind of referral and support for people who for the transition between prison and primary care. And what was also illustrated from Lauren's cases, and especially the last case, which was a very positive example, that the attitudes of the primary care providers are important. They have to restore trust in ex-prisoners. They have to restore the trust of ex-prisoners in the healthcare system and in primary care. They have to be non-judgmental and non-stigmatizing in their approach. I think these are elements that we can discuss now, and I would be very happy to give the floor to the discussion to the other people attending the webinar to have some more questions or a real discussion if possible. So I hand back to Anke.
Yes, thank you so much, Peter. And also thanks very much for setting the floor for discussion. And as always, it's so difficult to manage time during these webinars. So we have not that much time for discussion. And I looked at the chat box, Diederik, but actually there are not that many questions actually posed to the presenters. So maybe it is good to set up then the last slide of Peter with some conclusions and some issues, exactly the elements for the position paper. There are quite some slogans already around prison health. It's as one of them is good prison health is good public health. That is what you are addressing in the first bullet point. I have always a problem with that because that I think then actually do not acknowledge, that slogan does not acknowledge also the fact that the prisoner, the detainee should have good care, individual care by itself. But in fact, it shows, of course, very well that a prisoner is part of a society, is part of the community, and also returns to society. Another element, and that is what I heard in a discussion last Friday I had with one of the previous directors, former directors of prisons, and also with a doctor, a GP who's working in a prison. That's Hanneke. She's also attending this webinar. And one of the issues was also that actually the average time of a prisoner in prison is 3 months in a Dutch prison. So, you know, that is not that much. So what can you do in 3 months' time? Can you then set up, you know, a trajectory of a specific treatment or care? So there are quite some issues and elements around organizing that care. And of course, yeah, one thing, and I think that is also mentioned in the Nelson Mandela rules, in the Council of Europe guidelines and so on. Of course, that equivalence principle, and that is care in prison should be equivalent to care outside.
Anke,
yeah.
Maybe Hanneke can react to that because I see she is here. So maybe we can give her the word.
Yeah, Hanneke.
If you open your
We
microphone,
don't hear you, Hanneke. You have to unmute yourself.
I've been for more than 20 years GP in a small town, and I had a normal population. And the last 7 months, I worked at 29 different places, 11 prisons. Well, I do not know the word for TBS clinic. Maybe you can translate, Anke.
I don't know the English word for that.
Go ahead.
But, well, in Holland, they say the healthcare, the primary healthcare is the same in the prison as outside the prison. But I experienced that there's, well, quite a different way of working within the different prisons. So it's good to talk about it, because what ministry says is not what we can do at this moment. Many medical doctors, GPs, have to work in a normal practice. Otherwise, they cannot be registered. So it is not possible for me, after so many years of experience, to work for 3 or 4 days a week, excuse me, in prison, because after 4 or 5 years, I will lose my license. So
may I interrupt?
medical service.
Okay. May I
medical
interrupt,
service,
because this is an interesting issue, and I wanted to ask the same question also to Dina, because she presented us the whole range of ministries involved, and I think this is referring to a macro level problem that the different ministries are dealing with the care of those prisoners, and when they come out of the prison. And the direct question to Dina is there a budgetary reason why those ministries do not want to lose their say about the care provision of this group?
Thanks for your question. Actually, when these discussions took place, mostly they mentioned security reasons. That, for example, if the doctors who go inside prisons are part of they do not report to the penal authorities, but report directly to the Ministry of Health, the prison authorities say that it might somehow violate the security regime into prison. But of course, the budget restrictions also are a big part of this question, because if the system is lost, the main problem is that prison doctors will lose their eligibility to earn those military ranks, and they will have much lower salary and much less benefits available to them. And this might make the work in prison for the doctors even less attractive. And in this case, we might lose even those prison doctors who currently work there.
Thanks so much, Dina. That has been an ongoing discussion already for years in the Health in Prison project from WHO. What kind of ministry should be responsible for the prison healthcare? Either the Ministry of Justice, which is in some cases, some countries the case, or the Ministry of Health. And of course, WHO is urging for the Ministry of Health taking that responsibility. But that has been an ongoing discussion for years, and it is not finished. And one of the reasons is that what Dina mentioned. I'm looking at the time, and we said that we would have a 1-hour webinar, and I'm also then looking at Diederik and Peter, because I think, yes, Hanneke, but I would like to come up with a plan for maybe for next steps and maybe for a next webinar, because it is a very interesting topic, and I think what we have seen also with the number of registrations and the interest of people from all over the world, that there is definitely an interest to into this topic and to improve prison health. I suggest that we continue with our research, and that we set out the survey to a wider audience, and that we urge people to fill in the survey so that we can collect more cases of countries, so that we have a better overview on how prison health is organized. And then I suggest also maybe to organize another webinar with those cases, and maybe then focus a little bit more on the hurdles, so that we narrow down the discussion, because this, I feel really this as an introduction to the topic, and then we will ask for input for the position paper. I saw, Peter, that you have to leave. So I suggest that we in the working group will discuss this, and that we will come up with a plan. And of course, we will share that with those who have registered. Is there for now someone in the audience who is interested in filling in that survey? Because then we can directly send you the survey.
I would be very interested in other country experiences, and I know that there are people from Poland present, Belarus. Can I address myself directly to you, if you would be interested to join this working group and share your experiences in your countries? Please take the floor.
Diederik, may I suggest that you send the survey to all the people that are registered?
Yeah, I will do, definitely. That's agreed. But you can also try to reach me on a personal basis and see what are the opportunities. I explained in the chat box that we will provide the presentations in the PI platform, which is the discussion platform of the EFPC, to align all the different contributions. And I think it would be very nice to have you also present at this PI platform. But please send me messages if you want to have access or a further role in this working group. Yeah, I think that's it for the moment. We would have loved to have a bit more interactivity, but that's always difficult if you have a lot of people and a lot of people want to say something. There are a few questions which might be still to be answered. There was a last question of Sander van den Boom on if is youth detention also included in the position paper. Maybe Anke, you could directly answer this question and some other questions. I will collect them in a document, so then you can have a look at it. We will come up with a new date, and I wish you all a nice day, and thanks for attending. And Anke and presenters, thanks for presenting.
Thank you all. Yes, I also from me, very big thanks to the presenters of today, because everything was done in a very short notice. Yeah. So thanks very much for your availability. And we'll hope to meet you all again very soon. We keep you informed. And yes, very thanks for the question on youth detention, Sander. I think that's an important point, although that is a whole, different topic, I would say, than adult detention. But we definitely will have a look into that. Thank you all.
Thanks.
Have a good day.
Bye-bye.
Bye-bye.